It's my pleasure to welcome you, Ayan and Debbie. I want to ask you, Debbie, first, what's your first impression about the CVP conference?
Thank you, and thank you for having us. It's a pleasure to be here. I think it's great. I think that it's lovely to see a multidisciplinary of professionals come together, share their knowledge, share their experience in a way that is an open forum for them. They're allowed to have a voice, to talk about what is going very well in their trusts and their hospitals, what they want to learn from. I think it's best practice. We know that getting together and sharing practice in this sort of forum improves patient outcome ultimately, because we're all striving to do the best that we can, really. So certainly I think it's great, very impressive.
Thank you. Ian, I know it's your second visit to the GICVP, so what do you think about the second version since you've been here in the first version?
Yeah, it's wonderful to see it grow and develop and continue to be successful. The first one was incredibly impressive. That you pulled it off first time round, and it was already like, wow, this is so good. And then you've come back in a different venue, bigger format, more rooms, more speakers. The workshops are really good. So you've really grown and expanded and built on the huge success from last year, and it's just wonderful to see such a conference that has grown bigger and better than before. So yeah, congratulations to everyone. It's fantastic.
Thank you, Ian. My second question is to Debbie. What are the key similarities between UK and Gulf Cath Lab nursing workflow?
I think that's a really good question, and I was chatting to quite a few nurses about this actually. So there was a group, there was nurses from Kuwait, Oman, Saudi, and I think there's something to be said about an unspoken understanding of the concept of being a nurse and working in any environment. Patients will always need your care, so I think the theory always remains the same, the pathophysiology is always the same. There's great differences, I think, certainly within the structural side of it. We see that you guys are doing big volumes now, it's getting more frequent, and there's certainly a great deal of professionalism here, as there is in the UK. I've noticed that there's not as many TAVI nurses, and I think that the main difference that I've noticed is the fact that the nurses who coordinate the pathways somewhat over here also work in the labs, whereas in the UK we don't. There's a couple of centres that do, but I think in terms of getting patients in the system in greater volume, in a quicker time frame, you need a person for that role alone. So I think to share practice about that is really key. There was a huge paper done in the UK last year where they brought in lots of different nurses from various centres, and actually the centres that had coordinators doubled their number of TAVIs, and the patient pathway was a lot slicker. The wait time from referral to treat was much quicker, and the length of hospital stay was quicker. So I think it would be great if we could kind of share practice and adopt that. But certainly there's lots of things that are very similar. Protocols, policies in the cath labs, recording of data. It's been really informative today, listening to how they're moving forward from paper documentation to e-record, like electronic systems. And I think as a whole we need to acknowledge that AI is certainly going to be coming through, and we're probably all going to be doing very similar things. So there's a lot of similarities, but there also are still differences that I think we can all work together to move forward with.
Thank you, Debbie. I think we do have maybe the practice is a little bit different in terms of, as you said, the nursing, but we do have the TAVI coordinator, which is usually it's a staff member in the cath lab where they prep the patient for the TAVR, and then they actually get involved even during the procedure.
Yes.
But we don't have a dedicated TAVI nurse where I think, as I understand from you, does not participate in the procedure itself, right?
Yes, I don't participate in the procedure. I think if I needed to, I would have. I would have learned to crimp and things like that. And from a clinical side, I'm still very clinical. But in order to have the pathway smooth and get the key things that we needed to
Being more
focus on,
focused on-
yes, was pathway management. And, you know, the consultants and the nurses in the cath labs have got a very slick procedure. You know, we do single access TAVI, patients are in 20 minutes and they're out and recovered. We do 6 or 7 TAVIs a day. So that didn't need to be focused on from my end. It was mainly about pathway management and very patient focused of how do you actually get these patients in. And we're looking at mainly at the moment time from echo to referral, because we know that these patients have a massive high mortality risk, and it's about getting them in a timely fashion, and not just doing the procedure itself. I think the procedure, although it's the most crucial part, is the smallest part of the patient journey.
Thank you, Debbie. So, question to you, Ayan. Where do you see the most notable differences in daily practice, staffing models or role expectations?
Yeah, I think that's one of the really valuable things about conferences like these is it brings people together where we can really share these ideas. And particularly what you're doing with the CVP conference, a real focus on the nurses, the techs, the radiographers, where we can come together and really share our ideas and our practice. So I think this is valuable because we always live in our own little world, and to get out and see, we have shared challenges and shared perspectives is really useful. I find there's so much similarities. You know, you come away to different countries and different cultures and different languages. Actually, there's so much similarities. We all have the same problems, the same issues. We're very much patient focused. We want to constantly improve. So that's really valuable to see. It's very interesting. The work pattern is quite different, and you have a different way of doing things as we do in the UK. There's very similarities. Nurses, radiographers. I think your technologist role is very interesting. This combination of, we would have 2 separate roles in the UK, a radiographer and a physiologist that would do separate things.
You call them cardiac physiologists.
Yeah, so
which is
you've
similar
combined
to
this
the
two.
cardiac technologist.
Yes.
Yeah, so you've combined this 2 into one technologist. It's a really interesting role, and I think very something that we could probably learn from. Quite interesting, very good. So, yeah, but more similarities than differences is what I'm taking away. I think it's good.
It's actually in Saudi Arabia they are adopting 2 systems. Like, you know, the hospital that I work for is kind of like, you know, has an American rules or American policy.
Yeah.
It was established by Americans back in the days. So we follow the American, I would say, workflow and even the job description and the duty, where actually the cardiac technologists, they do the scrubbing part, they do the radiographer part, and they do the hemodynamic part. Plus, you know, the pacemaker clinic, integration, and all of the other stuff. But if you go to the majority of the cath labs in Saudi Arabia, you would see similar practice like the UK, where they have a dedicated radiographer, the cardiac physiologist, where we call them here cardiac technologists. They do the hemodynamic monitoring and they do the imaging, which is like the IVUS and the OCT.
Yeah.
And they have the cardiac nursing, where they do the scrubbing part and assisting the physician. So we have the 2.
That's interesting.
Yeah.
And do you think it causes any problems within the kingdom that you've got these 2 systems?
It's not. They adopted this. They've been having this for years. They are actually they find it as we mentioned yesterday in the round table. They find it difficult actually to change at this stage. Most of the people they adopted this. I believe only 2 hospitals in Saudi Arabia, which is our hospital and King Faisal Specialist Hospital in Riyadh, where they do the American way, where the CBT is multitasking, doing multitasking things. Some people, they think that they, you know, by doing this duty they are overwhelmed. You know, they are doing too much. You know, scrubbing, radiographer, hemodynamic, imaging, a lot of things. Where our nurses actually also they do the scrubbing part, they do the circulating part, they do the medication part, but they still maintaining the same skills, but legally we don't do medication, and for them they don't do radiation, but this is the only thing actually is different between us and them. Other than that, you know, everybody is doing everybody's job. And I feel this is actually it's very easy, especially when you have a shortage of staff, when you have staff away. Anybody can stand up and take the role and rock and roll.
It's interesting.
Thank you, Ayan. So my next question to Debbie: how can a global knowledge exchange like GIS CVP elevate CPPs internationally?
I think, just going over what we've said, I think that there's clearly a lot of people here who have extensive experience, and as well, it's really good to see, cath lab managers, radiologists, various people with such good, very sound clinical background. You can tell very clearly that the anatomy and physiology and the knowledge base is phenomenal. And I think if we all continue to unite and share practice, we can certainly drive cardiovascular health forward. It would be very ignorant to not acknowledge that structural heart is the future of cardiology, and there's various other things in that. But I think looking at up-to-date guidance, sharing best practice, sharing ideas within our own centres and what works well, what doesn't go well, continuing to do conferences such as this, where everybody gets together and learns from each other, I think is crucial. And I think people could take a lot out of your book actually and learn from you guys, because although we do it in the UK, it tends to be industry based. It's not like a national thing where we have these conferences, and I think it's certainly great to do. So very, very impressed with it. I think it's very good, and I've took a lot from it as an individual. Yes.
So would you please give us an example of something was new to you, or something that you're gonna take back with you?
Yes. So I think there's a lot of it. Today in particular, I think the electronic system for me was really good. I think it's good to see that people, like you said before, Ian, share the same difficulties in certain things, and auditing data, that sort of stuff. It's really important if you're going to drive change in any service and continue with improvements. And so I think, although we do it electronically, I don't think it's done all of the time. And so just thinking about how have people set those sort of things up, just what you were talking about before, the role, being able to adapt in certain situations to overcome staffing problems within the labs, for example, is very impressive. I know Copenhagen do that. I went over to their centre. They're a massive volume centre. I think they're near on 600 TAVIs a year. Their nurses or their staff, they move around and they can do the radiology part, the physiology part. Difficult in the UK because of legislation and things like that, but certainly something to think about and take from this. It's been very impressive.
The cross-training part, yes, it's difficult when you are bringing it as a new thing to them. Yeah, people feel like they're gonna be overwhelmed, they're gonna be abused.
Yeah.
So some people, they get they reject this idea.
Yeah.
I have a question about the electronic system. Do you have a unified system that goes over the whole UK?
Yes, NICO. So we have a system called NICO that we're all obliged to put all of our data into, and that's for all of the cardiology department. So they'll put in for every procedure, and it's very easily collated. Now the only thing is not everybody completes it, and so I was at a conference just 2 days ago with the BSIS conference in London, and the NICO data gets presented there yearly, and they were talking about compliance, and it's not always done 100%, which is really disappointing. Certainly even within our trust, it's difficult sometimes to record various things that you haven't necessarily done. PA pressures, for example, it's a necessity, but I think that it certainly helps us to look at the data, and it's very transparent. It's a very transparent system. We're all able to learn from each other and see who's performing at what level within the UK. But yeah, it's a requirement within every trust in the UK.
That's great. Thank you, Debbie. My last question gonna be for both of you actually. So, if you could standardize one best practice globally, what would it be and why?
I think Well, I'm an educator now. I've come out of clinical practice as a nurse, and I'm now teaching nursing, the future nurses.
That's why I picked the question.
So I think the education aspect really appeals to me. How GIS, you've got education packages embedded within your society, and I think that can grow, and you've got a real valuable place in education for CVPs in general. I love the game that you play, the Who Wants to Be an Expert. I think this gamification of education can be so exciting. It's really innovative to make learning fun. So I think taking that away so it's not a chore, it's actually a fun thing to do. So people want to be educated, want to be better at their job. I think that's fantastic, and seeing it done so well here is just really encouraging. So I'm going to take that away into my daily practice, see how I can make my job more fun for my students.
Yeah, well, actually, one of our board members who developed this game, they actually, as you see, last year we had the feud game last year. So they practice this in a monthly basis in their institution, where they do this game. That's why they have that experience. Yeah. And actually, we thought about it, and we decided to bring it actually to the conference. And we saw it last year. People loved it, and actually it changed. How sometimes people feel like the conferences become boring at the end of the day. So when you add that game, it's purely educational, and we actually have the winner get sponsored also for educational conferences to attend. So I think it was a good step that we did. People loved it, and we will continue doing it.
You've got the opportunity as a CVP conference. Most conferences are based around doctors presenting science, and it can be quite dry, and you've come in and said, let's do things differently, let's do things exciting. So it's great that you've taken that opportunity. So.
What about you, Debbie?
Yes, it's a difficult question because there's lots of things that I think you could standardise. It's not in the labs, I'll be honest, but the thing that I think that is the most beneficial thing to a service, certainly within cardiology, is a single point referral system. So all referrers referring into one port, and it being triaged appropriately, very quickly, by somebody who's got clinical background. So when I first came in post, our pathway varied greatly. We had some patients who were waiting for TAVI or other structural procedures for 30 weeks plus, really not hitting guidance. And I think it's, there's been lots of studies that show variation within referral pathways can cause harm to patients. So standardising it, having one port where all referrers refer into has made the biggest difference within our service massively. There's one other thing as well that I think is really important, and it's early mobilisation post-procedure. That has been really key in shortening our length of stay, but also, you've got it helps to reduce chest infections, DVTs, getting patients up when no muscle wastage occurs very early on in the patient journey. So early mobilisation protocol internationally, I think, will certainly start and get patients up, but that's about changing culture, and it's difficult to do. So we had to do a lot of education and really show a lot of leadership, I think, within different departments about getting your patients up out of bed quicker. So we have 2-hour mobilisation post-TAVI. Patients are up, and it's made a great difference. And I know this is now becoming standard, certainly within the UK. And when you speak to people, I was talking to a few colleagues in the US a couple of weeks ago at another conference, and they're mobilising a lot earlier now as well. So that has been key.
So this is now it's a standard of practice in the whole UK, or it's only in your centre?
Most places you're looking at about 3 hours standard of practice in the UK. We mobilise it to which all the biggest centres are doing, because we're doing a benchmark at the moment, and then we'll let them sit in a chair for an hour afterwards. But femoral access, providing there's no hematoma, no bleeding or anything like that, early mobilisation has definitely made a massive difference.
Let me ask you, how long did it take you to phase out from the regular way, which I believe everybody is doing, 2 or 3 days post-TAVI, to same-day discharge or next-day TAVI?
So we started our same-day discharge programme 2 years ago, February, and we've just hit about 25%. I had to do a lot of education on the wards with the nurses that are nursing these patients. Patients actually want to go home. The patients are the ones who really want to go home. We know that there's a lot of benefit in getting the patient home. Massive reduction in delirium, first of all, given the demographic of the patient. So I think to change the culture on the wards, I would say a couple of months at the most, but that is regularly going to them, doing education about the benefits of getting patients home, the benefits of early mobilisation. But to be honest with you, I think once they know that there's a key person, so for me, I'm the coordinator. Prior to me coming in, the wards didn't have somebody who would regularly come to them, do regular teaching, and I think when they know they've got that key person, it makes a huge difference. So I would say about 6 months in, we were well established in a same-day discharge, and now we're one of the biggest centres in the UK doing same-day discharge. We wrote the biggest paper, I think globally last year, on safety for same-day discharge, looking at ECGs and new left bundle branch blocks and the safety of it. We've published those papers, and so I think it's just about persistence. But in terms of time frames, I think you can do it safely. It's proven to be safe now, depending on how receptive the people are on the wards and within your departments. But certainly I would say for us it took about 2 to 3 months to get properly going.
2 to 3 months.
I would say so.
I'm sure you have a checklist for those patients.
Yes,
right?
we do.
Yeah,
I've written
I
a
would
SOP
love
for
to
that. Yeah,
if you
I'll
could
share that
the
with you.
checklist.
No problem.
And I'm sure also that some of those patients, they don't fall under this the criteria of same-day discharge for those patients, right?
That's right. So we're
So they go for 1 day.
1 day, yes. Anybody who has a pre-existing right bundle branch block, we exclude those. Although there was a recent paper, I think produced last week, that showed that actually was very little instance of complete heart
Just the
block,
branch
even
block.
with a right bundle branch. So anybody who's got pre-existing right bundle or like a trifascicular block, we would usually exclude those patients. So they are out of our protocol, and the patient has to have somebody at home with them as well the night of discharge to be able to ring if there's an emergency. And then within that, they're the 2 main exclusions, and the other 2 main reasons that a patient wouldn't go home. Some patients, especially with self-expanding valves, will develop a left bundle branch block post-procedure. So we've done a huge bit of research looking at the length of the bundle. So we've got very strict policy, but we do still discharge. There's lots of debate on this in the UK at the moment on a left bundle, providing it's not getting any bigger within a 6-hour period. And we haven't had any readmissions, thankfully, at the moment, but we are always very, very cautious about discharging patients home. But most of them want to go home. And we discharge on all platforms, so we use 7 valves in our centre, and we don't exclude any. Lots of centres in the UK do balloon expanding valves, and I would suggest that if you're going to start with the same day discharge, or any centre that's thinking about initiating a same day discharge programme, we've just wrote a UK consensus paper. It was presented at the BSIS 2 days ago, and we've put forward to present it EuroPCR. So it's a UK consensus led by the leading centres in the UK doing same day discharge, and there's a very strict guidance on there about how to initiate it in a centre and what the exclusion criteria and inclusion criteria should be from a safety perspective.
So does the distance included in the discharge criteria?
No, some centres were reluctant to discharge same
because
day.
It's a unified or a centralized hospital, right? So you get referral from everywhere.
Yes.
So people who are living let's say 100, 200 kilometers away
Yeah.
from you, how are you going to make sure discharging this, post-TAVI, next day, I don't know what's going to happen with him.
Yeah, so we send them home with a copy of their ECG just before discharge.
Okay.
We give them advice on it, looking for, hematomas, any red flag symptoms, dizziness, for example, mainly because of a bundle branch block or a complete heart block would be a main concern.
Okay.
And then we do a telephone follow-up the following day.
Okay.
All patients have a telephone follow-up the following day, and that's standardised within the UK. And then we'll give them contact information to contact any of us from a safety netted perspective, and recommend they go to the local A&E if they're feeling poorly. There was one patient who did go to the local A&E, but that was for an isolated pyrexia, and they thought that it was just a bit of a SIRS response following the TAVI procedure, and thankfully that it wasn't for a pacemaker.
We came to an end for our podcast. Thank you, DB,
Thank
for
you.
being with us in the podcast. Thank you, Ian. Thank you for both of you, actually, for being in the GIS, and I believe having you added value also to the conference. Sharing different practices and sharing different information, and we would love actually to see you next year on the third edition of the GIS CVP. Thank you very much.
Thank you very much.
you.
It's been a great pleasure to come over. Thank you.